Great. On today's agenda, you can see here we'll be covering introductions of today's presenters, a few housekeeping items, and how to operate this Zoom web conference platform, today's learning goals or learning objectives, housing updates to Policy Clarification Notice 1602, a little bit about how housing impacts Ryan White HIV/AIDS program clients, as well as profiling Washington State and some of the great work that they're doing there. We will round out today's webinar with some question and answer. So joining me today here at NASDAQ offices for the webinar is Christina Santana. Christina serves as a senior associate on our prevention and healthcare access program areas. We also have joining us from HRSA, Amy Griffin. Amy serves as a public health analyst in the Ryan White HIV/AIDS program. Some of you may be familiar with her as your project officer. We're really excited to have Amy joining us today. Thank you, Amy. So a few housekeeping items I'd like to review before we begin today. First of all, as I mentioned, this webinar will be recorded, and we will send out the recording with the slides as a follow-up message to you all tomorrow, as well as a webinar evaluation. We'd like to ask that everyone complete the webinar evaluation, as this information is really useful to us as we work to continue to improve our webinar and TA resources. The next item is that you all will notice you are on mute as you join the webinar. We ask that you do not unmute yourselves. If you would like to be unmuted to ask a question during the question and answer portion of today's webinar, please send Britton a chat via the chat box feature at the bottom bar. Next, again, the chat box feature that is on the bottom bar of your screen, you can use this to either send someone a direct message or send a question to the hosts to be asked during Q&A if you don't feel comfortable verbally asking it yourself. Additionally, if you need any troubleshooting or technical assistance, we ask that you send this request to us through the chat box feature. So these are the 5 learning goals or learning objectives we are aiming for you to accomplish as a result of participating in this webinar. I'm not going to go through them one by one, but I will just pause for a moment here and give you a chance to review. We're just going to take a moment now to transition to the presentation slides. Great. So now I'm going to go ahead and hand it over to our first presenter, Amy Griffin from HRSA HAB. Amy, I'm handing it over to you.
Hi everybody. Hopefully you guys can hear me. My name is Amy Griffin. I'm a project officer in the HIV/AIDS Bureau and Division of State HIV/AIDS programs. And I'm really excited that NASDAQ invited me today. The intersect between HIV, primary care, and housing is really a passion of mine. I'm the current chair of HAB's Homeless and Housing Work Group. And one of our goals is to educate internal and external stakeholders. So this is part of what I do. Prior to working for HAB, I've been at HAB for about 3 years. I worked for a technical assistance company that did work for the Housing Opportunity for Person with AIDS program, or HOPWA. And so I've sort of bounced back and forth between housing and healthcare and sort of live in that in-between space. So next slide. So I have you guys for a couple minutes, and I'm going to do, I know you all are very familiar with the Ryan White HIV/AIDS program, but I have a couple of just standard slides that we always introduce our presentation with. And then I'm going to give you some numbers about what we're seeing around unstable housing and temporary housing in the Ryan White HIV/AIDS program. And then talk to you a little bit about our policy clarification notice 1602 and the allowable services that you can provide with our funds. As well as some examples of things that people are doing that we've seen sort of out in community. Next slide. So this is the HAB vision and mission, and I think you probably all are very familiar with it. Optimal HIV care and treatment for all, which is what all of you do every day. And the way that HAB views our mission is to provide leadership and resources really to assist in the work that happens to assure access to and retention and high quality integrated care and treatment for vulnerable people and families living with HIV and AIDS. Next slide. So this is what we affectionately call the Ryan White HIV/AIDS program flower petals. And several years ago, when looking at a changing healthcare landscape and the role that Ryan White plays in that, we really developed this flower petal to sort of define all of the things that we do to achieve optimal HIV care and treatment for all. And, you know, I was reviewing it today, and it was just determined for the Ryan White HIV program in general. And I think if you look at it, it probably defines all of the things that you do as well as we do and that we collaborate on. So, you know, a public health approach to providing care for low income people living with HIV, and that's the center of all that we do. And we do that through service delivery, which is what all of our Ryan White Hearts do, policy recommendations, assessment, both from a system perspective and a client perspective, capacity development, and ensuring quality care. Next slide. So you all turn in an RSR report every year, and one of the things that our Division of Policy and Data has done is turn that into an annual client level data report. And that really was the result of feedback that we had received over a number of years of recipients wanting to see the data come back to them in a meaningful way that could be used. And so I wanted to just share a couple of items with you today. If you go to our website, you can find the data report if you haven't seen it. It also breaks things down by state. So there may be some interesting information in there and ways that you can use the data sort of for your elevator pitch around the ways that your program has improved health outcomes for people in your state. So we served in 2015, we served over 533,000 people. And I was surprised, I just heard this statistic recently, you may have heard it, that over half the people living with diagnosed HIV infection in the United States have been touched by the Ryan White HIV/AIDS program, and I think that's pretty astounding. Nearly 3/4 of our clients are from racial ethnic minority populations, and approximately 2/3 are living at or below federal poverty level. And another interesting statistic, about 80% of our clients do have healthcare coverage in some form. About 32.8% were covered by Medicaid, 10.4% by Medicare, another 10.4% had multiple forms of coverage, and 1/5 had no coverage at all. Next slide, please. So, you know, our big marker of how clients are doing is viral suppression. And you can see that we've really made a lot of progress in the Ryan White HIV/AIDS program from a national average of 69.5% in 2010 to 83.4% in 2015. And I think that number is fantastic. And I heard Dr. Cheever once say that, you know, in some ways we've, you know, the people who needed more education, we've hit, and now we really need to dig deep and get those last groups of people to be virally suppressed. And when you look, there's some key populations that are not doing as well as some of the other populations in our system, specifically younger age groups, some specific minority populations, but across the board, in a number of ways, people with unstable housing are not doing well in our systems. Next slide. So it brings me to a question that comes up a lot. You know, the Ryan White HIV/AIDS program is a healthcare system. It's a healthcare bill that authorizes us. Why should we care about housing support? And the The long and the short of it is that housing seems to be a predictor of both people at risk for HIV, but also for people not doing well in care. If you look at our numbers also from 2015 in the RSR report, 9.8% reported temporary housing and 5% had unstable housing. But if you look at all of the groups that have been prioritized nationally for assistance and for focus, almost all of them have unstable housing as well. And we see very clearly that people with unstable housing have lower viral suppression rates compared to those with stable housing. Next slide. You all may have seen this. This is just a visual representation of the data that we have from 2015 around housing status. So 85.2% were stably housed. The light green pie wedge represents those that were temporarily housed, and 5% is the yellow pie wedge, the unstably housed. Next slide. So I wanted to spend some time on this slide because this is really the heart of the matter. If you look at the red dotted line, that is our national average for viral suppression, the 83.4 number that I presented before. If you look at people who have stable housing, they actually fare better than that national average at 84.6%. And then it starts going down to, people who are temporarily housed are at 78.4%. And then unstably housed are at a very low 69.30%. And that is among the top 3 lowest groups, viral suppression numbers for any subpopulation. So it's really a key population, a key indicator that we need to address if we hope to raise that 83.4% viral suppression rate up. Next slide, please. So in 2016, we released a program letter announcing that we were going to expand the number of Ryan White parts that could provide housing support under the housing service category. Before that time, in our old policy clarification notice 1101, Part Cs were not allowed to provide housing services. And we received feedback from the Part Cs that they thought that it was a vital service for their client population, and we examined sort of the legalities around it, and in 2016 expanded it to that group as well. And so we're really excited about that. What we did was take away 1101. So if you go to our website, you'll no longer see 1101 as a policy. All of the relevant requirements or guidance around how to provide housing service are now encapsulated in 1602. Next slide. So this is the heart, this is what you can do with housing services. So this is what 1602 says. It allows housing services for A, B, C, and D. You are allowed to fund a housing referral. That could be a person who really works with people who are identified as unstably housed and helps them find permanent housing and helps to locate resources within your community for housing. You are allowed to fund short-term and emergency housing, and you are allowed to fund transitional housing. And I want to respond to a question that I get a lot, which is, what is transitional housing? How does Ryan White define it? And really, we indicate that the recipient needs to determine how long transitional housing can last, and we recommend that it be under 24 months. Essentially, there's a fundamental difference in transitional housing versus permanent housing. A permanent housing unit, you have a lease. If you follow the terms of your lease, if you pay your rent, then you are allowed to stay there indefinitely. Transitional housing is never intended to be a permanent location. It's usually part of a program that's transitioning somebody from homelessness or unstable housing to a more permanent option. But it's never intended to be a place where somebody can stay forever. So there's sort of a goal difference between permanent housing and transitional housing. The time frame needs to be determined by the recipient when you're setting up your service standards for housing. We have some additional guidelines. Again, it must be the payer of last resort. Excuse me. And that makes sense if you think about it. Why we only fund short-term emergency and transitional housing. We look to fundamental housing systems, usually those provided through U.S. Department of Housing and Urban Development, to be the primary funder of units. Ryan White is to fill in the gaps, to get somebody to those other housing systems, whether it's independent living on their own or some sort of permanently subsidized program. You must develop mechanisms to ensure that new clients are assessed and have access to housing, if that's part of your system. And you must develop annual long-term housing plans. And that makes sense, really. If you're providing housing support to a client, you need to be working with that client in some way to find them permanent housing. And that could be through a number of mechanisms within your system. It could be by leveraging housing case managers through another component. It could be through non-medical case management, or you could fund this housing referral position that we discussed before. And of course, you can always use rebate monies for these allowable services as well. Next slide. So we get a lot of questions also around the types of housing that our Ryan White partners are providing. And I'm really excited for Christine as part of the presentation. I've seen some preview, and I think there'll be some really interesting information for you about what is happening out in Washington. But in the meantime, I wanted to give you some examples. So the first is including, and some of these, before I start, some of these involve actually funding housing, and some of these involve leveraging your current housing systems within your community. The first is including your housing services in your planning processes. And I know you all just finished your integrated plans. Hopefully you had housing providers at the table with you. If you did not, I would suggest that you find them and invite them as you move forward in your process. I know that a number of communities identified housing as a need during the integrated plan process. And it's always great to have those experts at the table who can talk to you about the different ways that you can fund housing. And there are a lot of them, and some of them really aren't as intuitive as you would think, and require sort of investigating and knowing a whole new set of terminology. And so there are ways and there are people that can help you with that. You could focus on housing for a needs assessment study. So every year you're doing some assessment of emerging trends and what's happening in your communities. One of the things that you can do is look at who is becoming unstably housed in your system. How does that impact health outcomes in your system? And what can you do to focus housing services for those people that are not standing up well in your system and are not having the health outcomes that you would want? Co-located housing and care services. And, that seems really, a lot of people have heard of that, but there are a number of different iterations of that. I've seen where a housing intake person comes to the Ryan White HIV/AIDS program clinic and does assessments on a periodic basis. I've seen where there's a clinic located in homeless shelters that's doing testing and linkage to care. I've seen where there's actually been staff that go from the Ryan White Care Clinic to do intakes periodically at certain housing facilities, or have a case manager that's placed periodically at housing facilities. So there are a number of different ways that you could leverage those services. Targeted adherence programs for people living with HIV. So if we acknowledge that unstable housing is a predictor of poor health outcomes in our systems, then what kinds of adherence programs can we support for people who are experiencing unstable housing? And that doesn't mean necessarily paying for them. It's what we're good at. What kind of intensive medical case management, what kind of adherence services do we have to help people as they're transitioning from permanent housing to down to transitional housing, or if they're homeless? What kind of supports can we give to keep them adherent and hopefully virally suppressed during that process? The next couple have to do with acuity scales and assessment tools, and ensuring that you've included housing in those mechanisms, and that as you're rating people for acuity, if that's the type of system that you have, that unstable housing sort of raises somebody's acuity up, or at least contributes to points toward a higher acuity. Also that you're including housing as part of an overall care plan. Of course, resource commitments as available in your community. And I have the last one in red because I really do think that it is key. And I think some of our systems are really doing this well, but making sure that you have enhanced relationships with your housing providers. Make sure that you know who they are out there and that you have really great relationships with them. And in some cases, if you can, have data sharing agreements. We have a SPINS program that's going on right now that's looking at data integration and how to develop interventions by making our data operable, by being able to build data bridges between the HAB program and the Ryan White program. So there are ways that you can do that within your own communities. Next slide. So I did want to leave you all with some resources. I know that as care providers, it can sometimes be challenging breaking in and understanding all of the different HUD programs and how they work together. And how you can access them. So I thought I'd bring a couple of key ones out for you and websites where you could research them more. Of course, the HAB program, which you all know. HAB program is a really fantastic program, but it's not a whole lot of money. It's averaged around $330 million per year, and it's not nearly enough to address all of the need that I know a lot of you are seeing in your communities. So it's definitely worth looking at some of the other resources. This COC program is the McKinney-Vento Act. It actually, or the HEARTH program, and you can, it funds a lot of shelters, and it's moved in the last several years to funding more permanent supportive housing. So you want to take a look at that. It's an annual competition within communities, and they have a planning board that is similar to a Part A planning council, and you can, they're public meetings. You can always go to those meetings and learn about the COC programs in your community. The VASH program, which is a Veterans Affairs Supportive Housing Program, there are vouchers available for veterans to get housing. And so if you are assessing veteran status, it may be an option for some of the people in your systems. Public housing and voucher programs. I know that they're on wait lists in many communities, but it's worth keeping an eye on because I know that in some communities they periodically open up the wait list. And it's good to know that housing discrimination because of HIV and AIDS is illegal. And HUD has put out a whole resource guide on what that looks like and what options people have if they're being discriminated against. And so you can see that on that website. And then last, I just put a link to their housing and homeless assistance page so you can explore further if you want. Next slide. So these are our resources, Policy Clarification Notice 1602, which I'm sure you all have like a favorite button on your computer to get to. But if you don't, there's the website. Pardon me. And then the program client level data report that I love and reference in every presentation. And then, you know, if you're looking for other recipients in your area for whatever reason, there's the Ryan White recipient page, and you can feel free to also spread that among your subrecipients. And last slide. This is my contact information. If you have a housing question directly, it's always good to contact your project officer. They can help you explore how to use your funding to pay for housing, also how to leverage it. They also know where I sit if they need any assistance. You can always email me directly as well, and my information is on that page. So thank you for letting me talk with you. I love this topic, and I love sort of spreading the word about housing. And thank you to NASDAD for giving me this opportunity. I'll turn the floor back over, Christina.
Thank you so much, Amy. We really appreciate you sharing insight into last year's PCN 1602 and clarifying. We've been receiving a lot of questions over the last few months regarding what is allowable and what is not within the parameters of this PCN. We are very thankful for you participating and representing HRSA on this webinar. I'm going to go ahead and transfer it over to Christina, who's going to be covering a bit about our national housing profile work here at NASDAD, as well as covering Washington State's work. We're going to just pause for one moment the screen share as we transition into our new presentation.
Okay, so on your screen right now should be the Washington State Housing Program profile page. And just for some information, this is kind of a new approach that NASDAQ is taking to provide you all with information regarding housing services for your health, or to help support your health departments. We are creating this profile page as a resource for all of you guys to access as you look to move and to integrate housing services within your health department. As Mahalit introduced me earlier, my name is Christina Santana. I'm a senior associate on the Prevention and Healthcare Access team. And this profile, is, as we mentioned earlier, is looking at Washington State Department of Health and how they've started to approach housing services and look to integrate support within their community to address unstable housing and homelessness within the state of Washington. HIV and housing. I know Amy gave us a really great overview of why housing is so important for the clients that we serve, but I just wanted to provide you guys with a little bit more information. So we know that housing is the greatest unmet need for people living with HIV, and we know it's one of the strongest predictors of health outcomes. Housing support and stability play an important role in decreasing the incidence and prevalence of HIV in the community. Compared to those people living with HIV who are stably housed, those who are homeless experience worse overall physical and mental health. They have lower CD4 counts and higher viral loads, and they are less likely to receive and adhere to antiretroviral therapy. Housing stability also greatly contributes to a client's increased participation in risky behaviors like survival sex or substance use. As many as 70% of all people living with HIV report a lifetime experience of homelessness or housing instability in communities across the US. On any given night, 3 to 10% of all homeless persons are HIV positive. That is 10 times the rate of infection in the general population. Among individuals who are homeless or marginally housed, the rates of HIV infection are up to 16 times higher than those who are stably housed. The homeless MSM population is 15 times more likely than stably housed MSM to delay HIV testing. We also know from research that homelessness can delay entrance into care for 6 months on average. Homelessness and HIV have a complex relationship, presenting many challenges as providers work to improve disease outcome for clients. This benefits not only people living with HIV, but also those who are at high risk of getting HIV. So let's look a little bit at Washington State. The first case of AIDS was diagnosed in Washington State in 1981. Since then, more than 20,000 people have been diagnosed with HIV. As of 2015, there were more than 12,500 reported people living with HIV. Over the past 5 years, Washington has seen a decrease in incidence with about 470 new cases each year. With the success of decreasing new HIV cases, Washington State created the End AIDS Washington Initiative. The goals are to reduce new infections by 50%, get to 80% suppressed viral load across this continuum, decrease HIV mortality to 25%, reduce health disparities, and increase the quality of life for those living with HIV by 2020. As one of the initiative's objectives, Washington has included increasing access to safe and affordable housing. So on the profile, I've included Washington State's continuum. In 2015, they created this continuum, and if we look at the last column, the suppressed viral load column, we can see that they've been able to reach 70% viral suppression. As Washington State was beginning to think about how they could reach the 80% viral suppression goal of the End AIDS initiative, they decided to look at what other factors were impacting a client's ability to reach viral suppression. As we will see coming up, housing came up as a potential barrier, but also a possible solution. Homelessness in Washington State. On any given night throughout the state of Washington, an estimated 20,827 people are experiencing homelessness or unstable housing. Seattle-King County has the largest concentration of people in Washington experiencing homelessness at 10,730. That is a little over half of the total homeless population in Washington state. In 2016, Seattle was ranked as the 18th biggest US city, but it is ranked third as a major city with the largest number of homeless people, which we can see is a huge disparity. In 2015, Seattle Mayor Ed Murray and King County Executive Dow Constantine declared a state of emergency regarding the number of people who are homeless. By declaring the state of emergency, the city and county hope to bring increased funding and support to the organizations that are addressing housing services. Because of the gravity of the situation, eliminating homelessness has become a major focus of many community partners and health departments. HIV service providers are involved in a series of activities designed to best understand and tackle this critical issue. Efforts around this need are taking place at Washington State Department of Health with collaborative agencies. So I just also want to point out some of the photos included in here. On the back photo, we can see one of the homeless camps that are set up and largely concentrated near the airport within Seattle. These have been a point of contention for many reasons, with people looking to try and relocate the individuals within these homeless camps, as well as other organizations and things looking to address the actual needs for those who are living within these homeless camps. So within the profile, we've included some other pictures and a little bit more information. As Mahala said, we will be sending out the link to this, and you will be able to read through all of what's included in this. So before we get into the specifics of what Washington State Health Department is doing to address housing, I would like to share with you a video NASDAQ created that provides an overview of Washington's housing program.
I think we need to get folks stably housed before they can then get the other services they need. It's just important for any individual, but especially then if you have an illness like HIV that you need medications for and you need to get to the doctor. Housing is healthcare. If someone doesn't have stable housing, they're not going to be able to make sure that their healthcare needs are met.
Well, it's very hard to think about taking your meds or getting to your doctor's appointments if you imagine that you also don't know where you're going to sleep for the night.
Poverty is a really common factor in the lives of persons living with HIV in Washington State, and I know nationally. And we have such a small population left right now in Washington that's non-suppressed. So we're taking a look and kind of drilling down a bit. And housing is one of those issues that comes up kind of again and again from a provider standpoint as well as from a community standpoint. Washington State, we are one of the states that have an End AIDS campaign to reduce community viral load, make it impossible to transmit HIV in Washington State. We're doing this because we can. We have the dollars available, and this seems like a really smart investment.
We took our direct service programs from Ryan White Part B, our direct service dollars, moved that entirely to the ADAP program, and then used rebate dollars to fund case management, food banks, medical transportation, mental health, substance abuse. And we said housing is another one of those. And this time we want you to move it up in the priority.
It didn't come with a lot of rules, regulations. It didn't come with a set of specific policies.
We met with all 16 agencies individually and developed their contracts so that none of them look the same. Each one is crafted to what they identified as the needs of their community. Not all of those 16 agencies asked for housing dollars. And so we're looking at the agencies that are being funded for housing, looking at what they're able to do, and going to those agencies, to the agencies that did not request dollars, and suggesting, here's some services that you can provide in your community.
our larger agencies were really able to take that and start creating a real program out of it. They were a little hesitant because they thought, well, is this just a one-time deal? How much do we put in this? Do we want people to be dependent on it? I said, no, we're going to go with this way of funding our programs.
In our northwest corner of the state, we have HAB dollars available, and we have individuals who are sort of sitting on these vouchers with an inability to find a unit within the rental limits that are set by HABWA.
The housing that is sometimes available is not necessarily the best housing to be living in.
So what Department of Health was able to do for a couple of individuals in that pocket of Washington is to bridge the HABWA. So they were able to immediately house those folks in temporary units, month-by-month leases. They got them immediately off the streets. It created relationship. That buy-in is really critical to secure ongoing engagement and retention of those clients. So we know that there's a high risk of losing clients when homelessness is a factor, because I need to go where I can find housing. So that might be my cousin 3 counties away, and then the next month it's, you know, a friend of a friend. If we can keep people in one place, keep them engaged with the same providers, that's shown to produce much better outcomes in the long run.
We ran some of our pre-housing data recently and found that there was a very large difference between the number of people with suppressed, or the percent with suppressed viral loads, between those who were stably housed and those that were not.
We have a 90% suppression rate within our case managed clients who are stably housed. However, when I take a look at those individuals who are unstably housed, the non-suppression rate, so not virally suppressed, goes all the way up to about 33 to 35%. That's a massive difference. So we're going to be paying attention to that data point very closely.
The other thing we do is we spend a lot of time providing technical assistance. We do a lot of on-site visits with each of our contracting agencies. If somebody identifies to us that they're having a problem or they don't know how to solve it, we can then refer them to another agency and can facilitate that networking. And we do that on a frequent basis.
If it's about being afraid of how are we going to implement this program, we can help with that. Let's give you some ideas. Let's talk this through.
You may have to dig deeper into what the problems are. Somebody might not have stable housing because of other problems in their lives. So you may have to also then either start with or have a housing program that has other supportive services, mental health counseling, transportation, food. It needs to be a complete package to help that individual. People need stable housing in order to take care of the other needs in their lives.
Without meeting your primary needs, it's very difficult to then put attention to secondary or tertiary needs.
It's just one of those things that you just have to stop and think about, what if I didn't have this?
So now we're going to move to a little bit more information about the program implementation. In 2015, the Department of Health reached out to consumers and providers via site visits and needs assessments to gather information on community and client needs. Through this feedback and national research, the need for housing stability and housing-related services emerged. This prompted the Department of Health to add direct subsidy of housing and housing-related expenses to the menu of fundable services available to their subrecipients who provide case management services. As we saw in the video, 2016 is when the Department of Health began to encourage their subrecipients to provide housing services. Simultaneously, they held conversations with Public Health Seattle and King County, which manages the Ryan White Part A funded services transitional grant area. Understanding their methodology, process, and program structure was crucial to creating a solid partnership and further developing the Department of Health's housing program. By the end of 2016, the total number of unduplicated clients who accessed the housing subsidies was 122. Population viral suppression changed from 70% for those unstably housed to 90% virally suppressed within 6 months of achieving stable housing. Further, there has been an increase in case management retention. For new contracts in 2017, the Department of Health continued prioritizing housing for their subrecipients. The staff also developed regional housing status reports to identify utilization, gaps in care, and community needs. As the health department moves forward, they intend to continue reaching out to the community with questions and for guidance to truly meet the needs as they define, understand, and experience them. Program structure. Available housing services through the program include direct payment, non-voucher financial assistance for established rentals, deposits, transitional units, emergency motel, emergency shelter, essential housing related utilities, and application costs related to acquiring safe housing. All agencies currently funded under this category are additionally funded to provide case management. Clients receiving assistance for housing needs are additionally eligible for other Department of Health funded core medical and supportive services. These can include nutrition services, transportation, mental health and substance disorder prevention and treatment, early intervention services, psychosocial support, and outreach. The Department of Health currently measures program success by monitoring viral suppression rates pre- and post-housing subsidy, and by rates of retention in medical care and in case management. Moving forward, they will measure success by client retention in stable housing during and post-subsidy and overall population housing stability. As was detailed in the video, all funding comes from rebate dollars. For the clients that access housing service, there is a household income cap of 400% of the federal poverty level. This matches Washington State's current cap on ADAP, as well as all support services other than case management, which has no cap. Clients are eligible for housing assistance and subsidies for no more than 24 total lifetime months. So as NASDAD worked with Washington Health Department, we wanted to include a client's perspective and show how this program has helped. We were able to interview one client who received services from Pierce County AIDS Foundation, which is a subrecipient organization in Washington State.
I'm John Watson. I'm from Lacey, Washington. Grew up in Washington State. I have lots of health issues, HIV positive since 85. I have Crohn's, diabetes, I have heart issues, and my medications run $11,500 a month, and I need a lot of help. I quit work or retired from work for my health issues, and I had a home at that point, and I was getting behind in my mortgage because I was getting sick all the time, and then I go back to work and chase my mortgage. And I lived with my dad for about 2 years. My mother passed away, and my dad was getting lonely. He always had my mom in the house, and it was pretty much I helped him out. He helped me out. Then June 2013, my dad passed away. At that point, I ran my savings out, and I had no money to go anywhere. I was going to live in my car.
So when John first came in, he was in a stage of grief. He had just lost a parent, and with the loss of that parent, he'd also lost his housing. And the income that he had at that time was less than $200. So if you can imagine having that, how am I going to live on $200 a month? He was just like, he didn't know where to go, what to do, who to see.
Living in that car is not very safe and warm. And I'm thankful for this program, because if not, I would have been on the streets. And that freaked me out. I thought about suicide at that point too, because facing homelessness, I thought, I can't do that.
So what we were able to do was utilize our tenant-based rental assistance program. And with that program, the client pays 30% of their income. So we were able to use 30% of John's $190-some that he had. We found a landlord that was willing to work with us, even though his income was so low. So with that, we were able to get him moved in. We also had a supplement program where we were able to provide essential needs for John, like shaving cream, deodorant, dish detergent, those kind of things that you can't get with food stamps. In addition to that, we also made sure that John was a part of our food program where he was able to get a regular supply of food. So over the course of a year, we saw John go from this person that was very sad and just not knowing where he was going to land at, suffering from depression and grief, into someone that was in their own apartment, in a new community, happy to be relocated, and just like making his budget work.
And they said, we can get you down into Lacey, into an apartment, and we'll pay the rent for you until you get your Social Security. It took me a year, but I was very thankful because I've never been in that kind of situation in my life. I always made good money. And then when I had my house go up for short sale and I was going to be destitute at that point, I got lucky.
Housing is really an intervention. Housing, in my opinion, housing is medication. It's like it brings a stable building block where once a person is stable with their housing, then they can think about, okay, now I can make a doctor's appointment. Now I have a place where I can secure my meds. Now I can think about if I need to see someone with, say I have some mental health issues or substance abuse issues, I can begin thinking about doing those types of things. Whereas when you don't have housing, the last thing on your mind is my mental health or any type of substance abuse issue that I might have. So I'd like to say that that is another key kind of bridging, housing bridges to all those different services.
Because if someone in my situation with health issues, especially with HIV, you don't need to be on the streets. You need to be stable. You need to take your regimen every day. Housing is very important because without it, people are in danger, especially HIV people. We just don't function very well in homes. This is a great place. And thanks for everything they've done for me and my life in general.
Okay, so some lessons learned as Washington has moved through this process. Structural barriers can often create many obstacles for clients looking to attain or maintain housing stability. One of the biggest barriers is insufficient housing stock that is safe, affordable, healthy, and fit for human habitation. This consideration and others like community environment, landlord relationships, or access to needed services like transportation or medical facilities can deter clients from reaching stability. Additionally, client-related barriers can also have a huge impact on whether a client will be able to access housing. Things like credit history, eviction history, citizenship status, or criminal history can discredit the client before they are able to engage with housing authorities or landlords. The work done so far in Washington State is just the beginning of where the Health Department hopes to take it. As they grow partnerships, subrecipient support, and community engagement, I'm sure they will continue to see new incidence cases decline and increase positive health outcomes for clients. This profile is just one example of the great work that is being done to address housing services for people living with HIV across the United States. NASDAQ developed this profile and the National Housing Profile as a tool for your health departments to reference as you may be looking to integrate housing services into your program. At the bottom of this page, if you scroll all the way down past resources, you'll find two buttons. The first one detailing National Housing Profile, and the second the End AIDS Washington Initiative. In addition to Washington's housing profile, we've also created this National Housing Profile, which has housing-related systems and resources within it. You can, as we send out the link with information, you can feel free to look through it. On the End AIDS Washington Initiative page, that has more information about that, should you like more. Now we will take questions. If you have a question you would like to ask, please send a chat message to Britton's account and we will unmute you. We were going to unmute you all, however, we realized that that would result in a huge echo, and I'm sure no one wants that.
Great, thanks, Christina. So actually to kick us off, and as you all are kind of thinking through any questions you may have, we did receive one question through the chat box feature. So this participant wanted to know if we have any thoughts on how to support Ryan White, HIV/AIDS program case managers, as well as the HABWA team with obtaining long-term stable housing when the landlords don't want to rent to the clients that have a questionable background with arrests, drug use, etc. So while they have not experienced the landlord readily admitting that this is the reason for their denial, is because they have, sort of personal doubts about the renters, it's fairly obvious to the state, given the rent deposit, etc., that is not the problem. So we actually wanted to defer this question to you, Amy. Is there anything from your perspective you would recommend or suggest for health departments to do in when they're faced with a challenge like this?
That's a rough one. And definitely one I experienced when I was doing direct housing stuff. I think part of it is relationship building. If it's terrible in your community, you may decide that you want to fund one of those housing referral positions with, that I described when talking about 1602, somebody who can go build relationships. I've seen, for example, organizations that have volunteers who will offer to come clean the apartment after the client leaves as part of relationship building. I think there are different ways that you can do that. I would also get in touch with your Division of Community and Housing Development, whatever your housing resource organization is, and talk to them about how they build relationships with landlords. It may be that they have a pool that you haven't accessed yet, that they can help refer you to, or that they've worked with before, or they can give you information about how they build those relationships. It's certainly challenging, and I think part of it is working with landlords to understand what the win is, and that there will be some subsidy coming in if that's the case, or that they're working with people, whatever your client will allow. But it definitely is a tough one, and I think the bottom line is it often involves more intense work than sometimes we're all able to do. And so if you can find those leveraging partners who have done that work as well, that might help.
Thank you, Amy. Also, too, I just want to add real quickly that building off of what Amy was saying, I know with some of those partnerships, certain community organizations have been able to work with the more housing-focused organizations to create kind of like housing classes for clients, where they go through a series of let's just say classes, and then they like get a certificate or some sort of letter afterwards stating that the client went through this class and should be well equipped and informed about housing standards, and it kind of builds that landlord relationship with the community. Additionally, I know some housing organizations have like landlord meetings where the landlords can come and talk with the organizations, talk about the community that they serve. In that situation, it's a lot more general information about the community they serve. Generally, it's about individuals who may, have a bad credit history or things like that, and how the organization is working with those clients to address these barriers. So that might be some strategy you may want to look at as well.
So there's one additional question that we've received through the chat box feature. So the state is stating that in the past, they were told that deposits were not allowed as payment unless they were returned to the provider. And this person is curious of how Washington State is dealing with this issue. I just want to pause for a moment and see if we do have any participants from Washington State that are currently on the line. I believe there was a conflict for them, though. If there is anyone from Washington State on the line, could you please just send a chat message to either Britton Punn's account or to Christina Santana, and we will unmute you so that you can respond. Otherwise, we can follow up with Washington State and get a better understanding of how they've been dealing with this.
Also, Amy, is there anything you want to add regarding this question?
I am quickly looking up because I think we might have an FAQ and policy 1602 on that, but I don't remember the answer. So I'm going to look it up, and if I find something, I'll chat you and let you know.
Okay, perfect. So we will definitely mark that question so that we can address that at a later time, but we will be getting back to you.
Great. So we just want to thank everyone for participating on today's webinar. We are at time, so we're going to go ahead and wrap up for today. I want to send a very special thanks to Amy Griffin for joining us and for presenting on today's webinar. It's a pleasure having you, Amy. And I also want to thank Christina here on the NASTAD team for sharing a bit about Washington State's work. As Christina mentioned a few times throughout today's webinar, we are going to be making this housing profile for Washington State, as well as the national housing profile that she just briefly reviewed, available on NASTAD's website. So please keep an eye out for a follow-up materials from NASTAD tomorrow that include information about where you can locate the recording, as well as the webinar slides and the housing profiles. So thank you all again for joining today's webinar, and we look forward to your participation in next week's webinar, which is the second installment of the June webinar series from the Healthcare Access team. That one will specifically be covering Ryan White HIV/AIDS program opportunities to support population-specific work. Thank you.